Hello and welcome back to Clinical Cases. Today we're looking at the respiratory block again, so part 2, and we're going to be looking at the next 10 cases. So these are Paediatric and Adult Asthma, Cystic Fibrosis, Bronchiectasis, TB, Laryngitis and Pharyngitis, Empyema and Pneumothorax, and attention pneumothorax as well. So let's kick things off by looking at asthma. And this can be subdivided into Paediatric and Adult Asthma. So children who have a recurrent cough, wheezing, chest tightness, shortness of breath, and maybe chest pain as well are likely to have asthma. And the symptoms for paediatric asthma and adult asthma aren't too dissimilar. What's really important about this is if they're left untreated, then they often have less stamina than other children. But this doesn't need to be the case if it's managed effectively with bronchodilators. Normally, because they tend to have less stamina than other children, they tend to avoid doing physical exercise in order to prevent the exacerbations of their symptoms, so to prevent that coughing and wheezing. However, with the correct management, this shouldn't be the case. In terms of investigations for asthma, we would need to be thinking about spirometry. So asthma is a reversible condition, so compare this to COPD, where COPD comes up as irreversible. Spirometry will show asthma as being reversible. And spirometry allows us to assess the degree of airflow obstruction, so asthma is an obstructive respiratory disorder. And we can also do a peak flow in order to determine the maximum speed of exhalation in the patient as well. However, what's really important with these tests is it depends on the patient and if they'll perform. So don't forget, especially in paediatric asthma, that you're dealing with children. So essentially they may not perform to the best of their ability in a clinical environment. And with regards to pathophysiology, it's important to appreciate the pathophysiology of both a normal asthma condition, but also in an asthma attack. So first of all, if we look at normal asthma pathophysiology, you can start with T helper cells here on the left-hand side. And you must appreciate that this is a very, very simplified diagram leading to how we get inflammation of the airway. So it's a very simplified diagram, but if it helps you remember it, then by all means use it. So you can divide your T helper cells into T helper 2 and T helper 17. So if we first follow the pathway of T helper 2 cells, these can be subdivided into interleukin 2 and interleukin 13 and interleukin 5. So IL-5, interleukin 5, goes on to stimulate eosinophil activation, and interleukin 2 and 13 go on to cause B cells to produce IgE, the antibody, and then produce mast cell degranulation. And what's really important in terms of inflammation is this Th17, this T helper 17 cell, this interleukin 17, which will recruit inflammatory cells to the airway. Of course, asthma can be managed, so the aim of an asthma management is to be able to maintain control of the symptoms, independence for the patient, and as well allow them to have some stability in terms of exercise performance. So bronchodilators are a really good way of doing this in terms of relaxing the airway muscle, and corticosteroids are an anti-inflammatory medication which allow us to manage it as well. So looking at adult asthma, again not too dissimilar, so you've got the same pathophysiology along here, you've got the same symptoms, and the causes, so causes in adults we're thinking about how it's more common in the West. There may have been a genetic predisposition from when they were younger, and also maybe there's a link to whether they've had early exposure to bugs. In terms of on this slide, there's not too much dissimilar to what we've already discussed, so treatment is focused around bronchodilators and possibly anti-inflammatory medication. And investigation, this is a nice little summary of the investigations that you'd probably do to diagnose asthma. So FeNO, so Fe nitrous oxide, this is really quite a good diagnostic test for asthma, but it's not very commonly used. Spirometry and peak flow and skin prick tests are very more common, especially in GP practice. Just to flick back to paediatric asthma, we need to appreciate asthma attacks. So these of course can occur in both adults and children, and it's essentially representing severe bronchoconstriction. So the muscles are spasming, which means they're constricting, and therefore the lumen is going to be much smaller. So if you look at this diagram up here, you can see a normal airway on the left hand side progressing to a more severe asthma attack on the right. So in addition, the mucus layer, which is normally nice and round, has swelled up in reaction to this inflammation. So instead of this nice round opening we have here, we've got a much more amorphous opening here. The glands are also reacting as well, so they're filling up with mucus and secreting it into the lumen. But it's already narrow already, and it's becoming more narrow, and there's swirling mucus in there. And essentially you can see how there'd be a massive difference in the amount of air that's going through this bronchiole on the left hand side and the one on the right hand side which is suffering under an asthma attack. And therefore you get this wheezing which comes from the obstruction, both from mechanically narrowing the area and also from the extra fluid in there that the glands are producing. And as well, that's why you'd hear popping and wheezing when you listen, because there's bubbles that are building up in between the little bits of fluid. But you don't need to worry about that bit too much. So moving on, this is just a quick revisit of cystic fibrosis because it was covered in the foundation block. So if you refer to that video for information on cystic fibrosis. It's actually, just to revisit it, it's an autosomal recessive condition which causes a build-up of thick, sticky mucus in the lungs. As a result, sufferers tend to have recurring chest infections, they tend to have difficulty putting on weight, and frequent wet-sounding coughs as well. Delta F508 is the most common mutation which will cause cystic fibrosis, so it's a mutation in the CFTR protein, the cystic fibrosis transmembrane regulator, and the life expectancy for a cystic fibrosis patient is around 30 to 50 years. However, they can live a normal life if they adhere to strict management. This symptoms explored, so this is a little bit like your pathophysiology behind it. So why do they have the symptoms that they do? So they have sweat duct abnormalities, which causes more chloride in the sweat. They have pancreatic duct absence, so this is a real problem in terms of digesting food because they're not able to secrete those pancreatic enzymes. As a result, they have to take capsules at mealtime in order to aid digestion. Usually, however, leads to them possibly being a lower weight than normal people. And then you have this vas deferens epithelial abnormality as well, which usually leads to cystic fibrosis sufferers being infertile. Also, here there's the mutations which you can reference. So, in relation to this diagram, which was taken from one of the lectures, which allows you to understand the differences in the class mutations and which ones are more severe and which ones are less severe. Moving on, we looked at bronchiectasis, which essentially is damage to the airway, causing them to widen and become scarred. It is usually as a result of an infection or another condition that injures the walls of the airways and prevents the airway from clearing that mucus like it should. So as a result, the symptoms that develop are a daily cough. It's persistent, it won't go away over months or years. You have daily production of large amounts of sputum. You have shortness of breath and wheezing, chest pain, and potentially clubbing as well of the fingers. Causes, usually cystic fibrosis is the cause in around 50% of cases. However, the other kind of 50% of cases, essentially it could be congenital or acquired, and the acquired causes are TB, pneumonia, inhaled foreign bodies, those kind of things. In terms of treatment, again, links back to the cause, so depending on what the cause is, you can manage it going forward from there. So TB is something that was placed quite a lot of emphasis on in lectures and as well in therapeutics lectures. However, here I'm just going to cover the basic backgrounds to TB. So it's an infectious disease caused by the bacterium Mycobacterium Tuberculosis. It generally affects the lungs, but it can also affect other parts of the body as well. What's really important about TB is it has two states which you need to be aware of. So it could be the latent stage, which is where the bacteria is inactive, so it's not causing any symptoms in the host. Alternatively, you could have an active state where the patient is exhibiting signs and symptoms, such as coughing, hemoptysis, chest pain, or pain with breathing, and so on. So as we've said, the main cause is this Mycobacterium tuberculosis, which is a small, aerobic, non-motile bacillus. And the diagnosis for this condition we refer to as sputum microscopy, or a Zell-Neisen stain in its formal name. It's really important as well for contact tracing because obviously it's a contagious disease, and so therefore we need to get in contact with anyone the patient may have been in contact with and perform a MAN2 test, which allows us to see if the skin goes red and essentially if they have TB. In terms of treatment, there are four main drugs that you need to know about, so isoniazid, rifampin, ethambutol, and pyrazinamide. So these were covered in depth in the therapeutics lecture, but I'm not going to cover them too much here. But just be aware that the treatment is 4 drugs for 2 months, followed by 2 drugs for 4 months, and compliance to this treatment is absolutely essential in order to prevent resistance building up in case of future infection. Laryngitis and pharyngitis is what we were taught about next, and these are actually quite simple conditions if you think about them logically. So laryngitis is swelling and inflammation of the larynx, and pharyngitis is inflammation at the back of the throat or in the pharynx. Essentially, laryngitis can be acute or chronic. it doesn't usually have any serious consequences, and usually it's quite a temporary condition. So if you think about your larynx in general, it's home to your vocal cords, and therefore vital to talking, breathing and swallowing, and therefore those kind of things are going to be affected when you have laryngitis. So you're going to have a hoarseness in your voice or a weak voice. You may have rawness of your throat and a sore or dry throat, as well as a dry cough. In pharyngitis, it often is difficult to swallow because obviously it's affecting the area at the back of your throat. Essentially, it sometimes presents with fever as well as a sore throat, and usually this occurs during the colder months, and it's quite easily spread. The incubation is 2 to 5 days, and usually you manage it at home, especially if it's viral. If it's bacterial, you can treat it with antibiotics such as amoxicillin and penicillin. Next, we looked at empyema. So this is a buildup of pus in the pleural cavity caused by microorganisms. So it often happens in context of a pneumonia, injury, or chest surgery, and it's one of the many kinds of pleural effusion. Essentially, it's split up into 3 stages, which you can have a little bit more of a read about here. But essentially, the symptoms which will be displayed are chest pain, which is worse when breathing in, so we call this pleuritic pain, dry cough, excessive sweating, fever and chills, and a general malaise or discomfort. You can manage it with antibiotics, particularly because they're bacteria specific, and we can also insert a needle into the pleuritic space to drain the fluid, or a tube, depending on how progressed the empyema is. Essentially, word association, so empyema, think about pus and think about it being an infection, and essentially this can be life-threatening if it is untreated. So if you think about your normal pleura, you've got your visceral on the inside and your parietal on the outside, and this empyema is a collection of pus in that potential space in between those 2 layers. Last of all, we looked at pneumothorax and tension pneumothorax. So a pneumothorax is a condition where air leaks out of a tear in the lungs, and it can cause the collapse of lungs. So people normally refer to this as a collapsed lung, and it causes air to collect again in that pleural space. So think about your anatomy of the pleura with your viscerals and your parietal layers. It's building up air in that pleural space. So the causes of a pneumothorax, it can be spontaneous, particularly in young men. However, it can be due to a chest injury most commonly, so blunt or penetrating. But do think about underlying lung diseases as well, which could have caused it. Pneumothorax symptoms are sudden chest pain, shortness of breath, tachycardia, and a cough and fatigue in some cases. In terms of management, we manage it depending on how big of a pneumothorax it is. So a small pneumothorax you'd want to observe, support, and hopefully it'll heal naturally. On the other hand, if it's a larger pneumothorax, you'll need to perform a chest drain by inserting a chest tube in between the ribs into the pleural space, and you can also perform surgery if the air leak is so large, essentially. But this is where we're heading to tension pneumothorax, which essentially is referred to as a sucking chest wound. So it's a major tear in the lung causing a very large buildup of air in that pleural space, and it acts in a valve-like way to trap the air in that pleural space. So every time you breathe in, it makes it worse. It does usually as well cause a mediastinal shift when it gets large enough, and you can see this on a chest x-ray by it pushing the heart over, and usually the trachea as well is also displaced. Again, it'll present with tachycardia like a normal pneumothorax, but it presents actually similar to a cardiac tamponade, so hypotension, tachycardia and hypoxia. In terms of treatment, we usually mechanically ventilate first of all, and as well it should be needle decompression followed by a tube thoracostomy, and this is normally performed in the emergency department. So that's absolutely everything for this video. Next time we'll be talking about some other conditions, and as always, if you do have any feedback, please feel free to leave any notes in the comments below, or please feel free to message me personally. Thank you very much, and I hope you found the video useful as always.